I have this one. Oh, you guys have it? All right, hello everyone, good morning. Welcome to this very important event. On behalf of MLI, I want to thank everyone for attending the symposium. It's titled Non-Small Cell Lung Cancer Game Plan, Navigating HER2 with Evidence and Insights. This activity has actually been supported by an educational grant from Bayer, but we want to be non-biased. We really want to promote education. We want to talk about this important space in non-small cell lung cancer. My name is Eric Singing. I'm going to be the MC and moderator for today's program. I'm from MD Anderson Cancer Center in Houston, Texas. And I'm pleased to be joined by my colleagues and my friends, Dr. Martin Dietrich, who is from US Oncology Network in Florida, and Dr. Josh Savari, who is from NYU in New York City. So thank you both for being here and offering your expertise on this subject. Before we get started, just a couple of housekeeping items. As we're getting set up, first you'll notice a really nice donut wall. I can already see that half of it's empty, so people are enjoying it. Please continue to reach out, grab some food. We want this to be interactive, and you need to have your calories and your carbs ready. This is a game, so we are going to be asking for audience participation both online and in person. You can access the pre-test and downloadable practice aids and claim your CE credit using this QR code that's shown up here. It's also available on the tables. The data we collect is going to be really helpful for determining the effectiveness of this activity, making sure that people are walking away educated, empowered, and ready to help care for patients in this space. So they will be talking really about HER2 alterations in non-small cell lung cancer, and like I said, this is a game show format. We want this to be interactive. It's the last day. Everybody's ready to travel home. Hopefully flights are not too delayed, and so we're going to make this as encouraging and interactive as possible. So to get started, we're going to go to this next slide here. If you are online, you can link to this website here. This is Mentimeter. It's an online polling platform. If you're here in the room, you can also go ahead and scan the QR code. We're starting off with a very easy question, and it's what's your donut preference? So everyone should have one. So take a second just to log on to that. There's no right or wrong answer. There's no judgment here. So please give us your best response to this polling question. We'll give it a second just for everyone to scan in. That's the right one. Okay, there you go. All right, I see phones still up. I'll wait until half of them go down. Perfect. All right.
You getting it?
All right, there we go. And we've got a dancing donut on the side there. So glazed, really? Most people chose glazed. Interesting. All right, chocolate is gaining traction. Love that. Josh, that seems like that was your vote.
I'm a chocolate guy.
Okay. Glazed and chocolate. Wow, nobody wants Boston cream.
Too many calories.
At least nobody said who eats a donut. We have gluten-free options as well, too, for donuts in the back, so we're trying to accommodate to everyone. All right, fantastic. Thanks for entertaining us and getting an answer there. All right, so this is just a little bit more about getting CE and CME credit. If you want to obtain that, you can do that with this QR code. These are our disclosures, and we'll go ahead and get started. Game on. So I think we already went through that polling question. Let's set the stage a little bit, right? So we're all here at the North American Lung Cancer Conference, so obviously our topic is going to be about lung cancer. Lung Cancer Awareness Month just happened last month, right? And so it was a really important time in November, but our continued education, empowerment, and awareness for the lung cancer space should continue throughout the entire year. It's the second most diagnosed and yet the deadliest cancer worldwide. I tell my patients usually that if you have a diagnosis of lung cancer, it's about 80 to 80% of cases that are non-small cell lung cancer specifically. Mortality remains high for all non-small cell lung cancer cases across different stages, so the 5-year survival rate is just shy of 30%. We are seeing advancements in our treatment armamentarium for patients. We now have targeted therapies in addition to chemotherapy and immunotherapy. Really important to understand biomarker testing and biomarker results in the non-small cell lung cancer space so we can offer precision medicine to our patients and their families. We're going to be focusing, like I said, on HER2 alterations specifically today in non-small cell lung cancer. And what we know is that previously we've had difficulty with delivering targeted drugs in this space to our patients. Yet we're continuing to really redefine the space, and then instead of the year 2025, we finally have some oral targeted options, which we're going to talk about, that are now FDA approved. So HER2, it stands for Human Epidermal Growth Factor Receptor 2. It's a mouthful, HER2. But you also need to know ERB-B2. I talk about this all the time. All of the lingo can get very confusing, but oftentimes you'll see synonymously that they both should be mentioned, and if you have a NGS report or biomarker testing report, you may see one or the other, but they both are meaningful to know, and I strongly believe that. Hyperactivation of the HER2 receptor can really cause dysregulation because of various mechanisms. So you can see cell growth and survival, secondary to tumor hypoxia and angiogenesis, epithelial to mesenchymal transition, which we can talk about, and tumor immune escape. So this is just showing and sort of setting the stage about how we see tumor genesis in patients that have HER2 positive non-small cell lung cancer. So there are different mechanisms from hypoxia and angiogenesis, as I mentioned, epithelial to mesenchymal transition. And you hear a lot of times that patients that have HER2 positive disease have this cold tumor microenvironment, which allows for tumor immune escape. And so they don't tend to respond as well to immunotherapy by itself. All right, so now is the interactive portion. So everyone's got a donut, I see coffee. We've got flags on the table. So if you're online, you're gonna see an option for myth or fact. So very straightforward, but here's the rules. There's gonna be 8 rounds of HER2 altered non-small cell lung cancer myth versus fact statements. Once the statement has been made, you're gonna raise your red flag if you're here in the room, if you think it's a myth. Raise your green flag if you think it's a fact. Don't hesitate. Raise your flag proudly. If you're online, click with confidence, okay? So we have the online participant QR code too. We'll give it a second just so everyone digests sort of how to move forward with the myth versus fact game. All right, so statement number 1. HER2 alterations in non-small cell lung cancer are similar. Who thinks this is a myth or a fact? All right, I can see the online votes. It's split between myth and fact.
I can't see everyone's flags. There we go.
Oh, yeah, there you go. Thank you. Okay, I see in the room mostly the myth flag raised, and online we're 20% fact, 80% myth. All right, the answer is myth. So round of applause for everyone in the room for getting it correctly. So HER2 alterations. We can't really just say HER2 alterations. Josh and Martin, I'm going to pick on you guys a little bit to offer some more insight. But really, there's different types of HER2 alterations. So with that, maybe, Martin, do you want to start with talking about them?
Yeah, absolutely. Thank you so much for coming, everybody. It's good to be with you today. And HER2 is obviously very complex. It's probably one of the most challenging and most widely distributed biomarkers that we see. As you know, this was actually the first oncogene that we were targeting in the 90s with HER2 in breast cancer, the monoclonal antibodies. In lung cancer, the spectrum very different. We have here, and I think that's a big part of our discussion today, the gene mutations. Those are activating mutations, typically in exon 20, so a little bit different from what we're seeing in EGFR, where we have other exons more preferentially affected. We see the gene amplifications. We don't really know if they're true oncogenes. Oftentimes we think of them more as resistance mechanisms, where we have multiple copies of a gene in linear alignment and basically leading to an overexpression. And this really following a linear pattern when we have a 10x amplification, and we have a 10x overactivation when we look at downstream targets and expression. And then obviously the epigenetic regulation. This protein overexpression can actually be two things. It could either be a consequence of gene amplification or an epigenetic regulation. So this is even more challenging. And we look at the protein overexpression largely as a homing molecule for antibody drug conjugates. But the gene mutations are the true bona fide oncogenic driver in non-small cell lung cancer. And again, this is very different from our breast cancer or upper GI experience or endometrial cancers, where we really think about amplification as the main driver. So the gene mutations really the focus for us in treatment. Josh, I'm not sure if you have anything to add.
I completely agree. I think we have to differentiate these in the clinical setting. We have to understand what are the right testing modalities. So gene mutation, gene amplification, generally next generation sequencing. Protein overexpression is generally identified by immunohistochemistry, and really understanding that in the breast cancer community, we're talking about protein overexpression generally by IHC. In lung cancer, you're going to hear a lot today about HER2 mutations, most commonly the YVMA, and that's by NGS. So really important to differentiate those. We're better studying therapies across these different alterations in HER2.
Yeah, I think you both summarized it very nicely. So there's a few different categories of HER2 alterations. We as thoracic oncologists have been learning from our breast medical oncology colleagues, right, taking a page out of their book. Right now, gene mutations seem to be very prominent. We're going to talk about some of the FDA approvals that we have in that space, and there's different ways to test for these different alterations. So just because you got biomarker testing doesn't mean you necessarily test for all these different types of HER2 alterations. Thank you both. All right, we're back in the game, so get ready for your flags. Next statement here, HER2 mutant non-small cell lung cancer is common. Myth or fact? Okay, all right. So I'm seeing a few different answers in the audience, but for the majority, it looks like I'm seeing myth. Online, we're seeing 25% fact, 75% myth. So the answer is myth. So HER2 mutations, they can occur in about 1 to 4% of patients with non-small cell lung cancer. You'll see the statement here, they tend to be more prevalent in patients who are females, Asians, have no smoking history, and who have lung adenocarcinoma as their histology. But I really want to emphasize that you don't have to be one of these particular demographics to have a HER2 alteration, and I strongly believe that all patients with non-small cell lung cancer deserve biomarker testing. You won't know unless you look. I'm going to pass it to you. Josh, maybe you can talk a little bit about this.
Sure. I mean, so HER2 gene mutations, as we mentioned, I see them about 2% of my patient population. Now with novel therapeutics coming, we actually are seeing it a little bit more frequently with the trials that are available, probably 3 to 4%. Almost 90% of these mutations are occurring in the tyrosine kinase domain. This is the sort of machinery of the gene. And most of them are occurring in exon 20. And the most common one is the YVMA. It's interesting that there is not much overlap between gene mutation and amplification or even protein expression. So Martin, how commonly are you seeing this in your clinical practice? And are you getting IHC and NGS on all patients?
Well, I mean, that same gene, different levels of targeting. So we get both. We do need IHC for HER2 as well as the mutational analysis. There's really no correlation. The HER2 mutations really don't necessitate overexpression for overactivation. So we can very well see a HER2 1+ by immunohistochemistry with a positive mutation detection in HER2 in the YVMA domain.
Yeah, and the way I explain to patients with the HER2 gene mutation, you have constant activation of a signal to grow, and that is really simple or therapeutically, more straightforward to target or block. But amplification and overexpression, we know, is a different biology. So again, really important to differentiate these in our clinical practices.
Yeah, thanks for that. And the other point I'll emphasize, I see a lot of young patients with lung cancer at my institution. And so for me, it's not 1 to 4%. It's close to almost 15 to 20% of the patients I see. So really, it's important to understand the patient population that you're seeing. Don't take away the opportunity for biomarker testing for these patients. And I think what you both highlighted was the results may not be concordant, right, with NGS testing and what you have on IHC. So just because you've checked for a HER2 alteration using NGS or your favorite profiling platform for biomarker testing doesn't mean that you've checked the tissue as well for protein overexpression. So I think those are important.
And this common versus uncommon, I think, is an interesting idea. I mean, if you look at RET or ROS1 or BRAF, these are occurring at 1% in our patient population, and we know that lung cancer is multiple diseases. So HER2 mutations at 2 to 3% is 3 times more common than ROS1 or RET. So again, despite it being less common or rare, it is a prominent driver of lung cancer in our clinical practice setting.
All right. Any more details that you guys want to offer about gene amplification?
I mean, you're the scientist here. Tell me about gene amplification. How come we can't target it, and how come it has not been that successful? And what is the correct cutoff for amplification? Amplification being copy number alteration of the gene, so many copies of that gene, as opposed to a mutation in the gene itself.
We don't really know. I want to keep this short. Gene amplification is a descriptive event in lung cancer. We don't have a cutoff. We don't really know if it's an oncogenic signal. We know that there's great interest in looking at this, but for now, this remains an observation without any therapeutic consequences.
Thank you both. All right, round 3. We're going to move into rapid rounds. HER2 overexpressing non-small cell lung cancer is defined similarly to HER2 positive breast cancer. Myth or fact? All right, I see some people not even voting. Come on, guys.
Come on, everyone, let's vote. We're 3 in. Let's go. Let's get it going.
All right. So for the most fact, it looks like most people are saying it's a myth. I do see a few facts. Online, there we go. It's split, 50-50. It's a myth. So HER2 protein overexpression in non-small cell lung cancer, we'll talk a little bit about sort of what that means and its definition, somewhat difficult to define due to its varied frequency, which is different from breast cancer. Maybe, Martin, do you want to talk about HER2 protein overexpression?
Well, the overexpression defined as 3+ by immunohistochemistry is actually very similar to breast cancer, in honesty. So there's not really a big difference in overexpression. Again, it is not an oncogenic target. It is a target for antibody-drug conjugate uptake. So it's a little bit different in the biology than we would expect. But the definition is actually quite similar. Yeah, we don't have an amplification cutoff that would correlate with an 3+ like we do in breast cancer. But if you look at immunohistochemistry exclusively, it is similar.
Yeah, and important to note, I see this as 3+ in 1 to 2% of my patient population, and there is an approval for trastuzumab deruxtecan. It's an agnostic approval in this setting.
Thank you both. All right, round 4. NCCN guidelines recommend liquid biopsy to identify HER2-altered non-small cell lung cancer. Myth or fact?
Are you using liquid biopsy, Martin?
And every patient. It's the easiest. The why not is very small. Injury to the patient is 0. So in every patient in the NCCN guidelines.
So the vote is in the room. I'm seeing a lot of myth flags raised. Online, interestingly, more fact. Myth. So let's go into the explanation here. NCCN guidelines prioritize tissue biopsies and define it as our gold standard for non-small cell lung cancer biomarker detection. I'm seeing some head shaking over
I'm
here.
going to push back here. I think
Yeah.
we need to do both tissue and plasma in all
Yes.
patients, and I think they're complementary of one another. And Martin, as you mentioned, plasma, you understand the heterogeneity of the disease, but yes, tissue really is the gold standard. And if the plasma is non-diagnostic, you do need to fall back on tissue NGS.
Any other comments about just ctDNA, liquid biopsies in general?
It's a small mutation. It's very well detected on liquid biopsy. So I would say disagree with the NCCN guidelines here. This belongs together. And
We have to vote. We have to vote to get you onto those guidelines.
And I'll say in my practice too, I'm concurrently, checking for liquid biopsy and also tissue biopsy.
Every patient, every histology.
Absolutely. All right, we'll skip forward here to round 5.
Ooh, we're getting real controversial now.
Immune checkpoint inhibitors, ICI monotherapy, is not effective in patients with HER2 mutant non-small cell lung cancer. Myth or fact?
Ooh,
there's some
no
hesitancy
flags.
raising
Whoa, whoa.
the flags.
Raise your
Yeah.
flags. Let's see. Come
No
on.
one's
Let's get.
being proud here. Okay, I see.
Put your dollar down.
Fact, myth. Wow, every table has got a little bit of discrepancy.
Well, are there no flags at that table? What's going on? That one too. All right. This
We'll
is
allow it if you're eating your donut. All right, online is going back and forth, 56, 44%. It's kind of same thing in the room here. So fact. Yeah. So I saw you raise your eyebrows, Martin, about this, but the statement here is immune checkpoint inhibitor monotherapy has not shown positive results in treating patients with HER2 mutant non-small cell lung cancer. Tell us about that.
Well, we don't really know. There's no specific trial that evaluated immunotherapy in HER2 mutant disease. There's a lot of alignment with the biology of EGFR, where we think that checkpoint inhibitors are not effective. The data that we have is descriptive, and we don't think that immune checkpoint inhibitors really contribute much. But we can't really point to a study that says don't use it. So I think the 50-50 split reflects the ambiguity in the data. Whether you use it or not is really preference dependent, but I would adjust my prognostic expectations for the use of immune checkpoint inhibitors.
I'll push back a little bit. A young, woman, never smoker, low PD-L1 expression with a YVMA, HER2 exon 20. That patient is not going to respond to immune checkpoint inhibitor. I exclude it in the frontline setting. But an older patient, maybe with SQAME, heavy smoker who has HER2, uncommon, but it occurs. Maybe that's a patient who may be deriving more benefit.
I think the granular call is very reasonable, for sure.
Absolutely. All right, round 6. Trastuzumab is just as effective in HER2 mutant non-small cell lung cancer as it is in HER2 positive breast cancer. Myth or fact? These are getting harder. All right, a lot of people throwing up the myth flag. A few facts. Online, most people are saying myth. Myth. So monoclonal antibodies, including trastuzumab, have not shown benefits to patients with HER2 mutant non-small cell lung cancer. Josh, I'll give this one to you.
Yeah, so it's interesting when we look at some of the older agents, trastuzumab plus pertuzumab, response rates quite low, 8%, median PFS of only 4 months. But some of our more novel therapies, we are seeing better activity in this patient population. But clearly in breast cancer, these drugs have been more successful than in non-small cell lung cancer.
Absolutely. All right, round 7. There are several new treatment options emerging for our patients with HER2 mutant non-small cell lung cancer. Myth or fact?
Come on, let's make this
I
100%.
heard someone said, what is several? There's always room for improvement, right? Oh, but I see a sea of green out there. That makes me really happy. And online, we're seeing that as well. So, fact, we can proudly say that. So trastuzumab deruxtecan, newer generation TKIs, tyrosine kinase inhibitors such as cevabertinib and zongertinib with new FDA approvals as of 2025. We have those options for patients. There's continued phase 3 clinical trials trying to move these drugs forward in the frontline setting. Tell us a little bit about these emerging treatment options. I'll give this one to you, Martin.
Well, I mean, there are a number of them. I mean, we started actually with the first ADC, trastuzumab and emtansine as the first one that we sort of used. It wasn't approved, but we had some data here. The first one we've had approved here was trastuzumab deruxtecan. We talked about the ADCs. And now, in a very short sequence of events, the approval of zongertinib and cevabertinib in a very similar fashion to tyrosine kinase inhibitors that are targeting the intracellular kinase domain pocket. We've had very good response rates, and this looks very much like what we would expect from a targeted therapy. Very high response rates. Want to see effectiveness in the brain, and also durability here is quite good. So we just have to sort of sort our thoughts when it comes to prioritizing these agents, and I think there are certainly many considerations that we'll get to here in a second. But what do you do in your clinic?
Yeah, I mean, so you have 3 approvals now in the second-line setting. They're all accelerated approvals, trastuzumab, deruxtecan, and ADC. To me, the response rates are a little lower than what I'd hope for a targeted therapy. So I would focus more on a tyrosine kinase inhibitor, and we have zongertinib, which was approved a couple months ago, back in August. Median PFS, we saw north of 12 months. Response rate north of 70% and very well tolerated. It's HER2 specific. We just recently saw the approval for cevabertinib as well. It's a HER2 and EGFR exon 20 inhibitor with similar response rates and similar durability. So I really have a discussion with the patient. My go-to is zongertinib, though, in the second-line setting, and I hope that we can see approvals here in the front line. So 3 ongoing frontline studies. Martin, what are your bets?
Well, I think they... to be determined. Unfortunately, none of them really asked the questions of which of my preferred agents would be. They all go against the Keynote 189 regimen, which in my opinion is probably a non-established regimen in the subset of HER2 mutant disease. So we'll see what the data shows. Hopefully they all move to the frontline setting. We definitely want to have that flexibility to not have patients to move through chemoimmunotherapy before they get to much better agents in my perception.
And select patients. I'm even using off-label TKI on the frontline. Curious if you're doing that at all, meaning that, you know, I really believe the data is better for those agents, and I keep trastuzumab deruxtecan in my back pocket.
Yeah, I mean, I'm very excited. First of all, just how fortunate we are to be able to have these options, right? I used to tell patients that we had FOMO here in this HER2 space. They did not have the oral targeted therapy option, but that's over as of this year, so I'm really excited about that. I encourage clinical trial enrollment to help us answer this question. Very importantly, you both noted that the control arm for these ongoing phase 3 studies is chemo IO, right? And that's already a little bit controversial. But I think the sooner we can move these targeted therapies into the earlier settings for our patients, I really feel strongly there is going to be a benefit that we're going to see, and it's going to be meaningful. All right, this is the last one for the myth versus fact game, so proudly raise your flags. Patients with HER2 mutant non-small cell lung cancer are more likely to develop brain metastases than patients with other genotypes of non-small cell lung cancer. Myth versus fact. All right, looks like in the room a lot of green flags, some red flags. Online, more fact than myth. Fact. All right, so patients receiving treatments for HER2 mutant non-small cell lung cancer are more likely to develop brain metastases, 28%, than patients that have a KRAS-driven disease, 8%, or EGFR mutation, 16%. Josh, what do you think about this?
Yeah, I mean, in my patient population, upwards of 40% of these patients will develop CNS metastases, upwards of 15 to 20% de novo up front. So having therapies with great CNS penetration is going to be really important. And also to clinicians in the room, you need to monitor the CNS. Yes. You need to get routine MRI brain. How often are you doing it in this patient population?
Yeah, I feel very strongly about this. So if you go to NCCN, you're not going to get clear recommendations in terms of what to do in terms of surveillance for your patients. And I feel very strongly that for patients with actual genomic alterations, we need to be watching the brain. We need to be careful. Many of these patients are young. They're still working. They're the primary caregivers of their family. And so developing a CNS metastasis and waiting for symptoms to arise and then go check, that's a time and an opportunity where quality of life may be impacted, everything that they're doing. So I feel very strongly. So at minimum, I'm checking every 6 months.
Martin, same?
I do every 3 months for patients with the CNS metastasis at baseline, every 6 months for those that do not.
Yep.
Same in my practice.
Yep. So yeah, so you can see here some studies greater than 50% of patients will develop brain metastases with HER2 positive disease. All right, well, thank you all for playing the myth versus fact. Let's give ourselves a round of applause. Appreciate it. All right, the games continue. We're moving to case craze. So if you can go ahead and scan the QR code, or you can visit menti.com. We'll take a second for you guys to get logged in and also logged in online. And then we'll go over the rules.
Who won the flag game?
Everyone is a
Oh,
winner.
all right. That's what I tell my kids.
All right. So these are the rules. You'll use the QR code as you have already started logging in to access the polling platform to participate and provide some answers. There's going to be 3 cases, of example cases of patients with HER2 mutant non-small cell lung cancer. What are we doing? How are we managing them? We'll talk through some of the data and the clinical decisions that apply. Okay, so round number 1, I'll read this case out loud. You have a 59-year-old female patient who is a patient that has a lifelong no smoking history, has no known comorbidities, and presents for her first clinic visit with a 3-week history of chest pain, cough, and shortness of breath. The cough began as a mild and dry sort of presentation, but became more frequent. The patient started to describe the chest pain as central tightness. It's worsened by coughing and exertion. Following an unsuccessful cycle of antibiotics, you order chest imaging and observe a pulmonary lesion. Which of the following clinical decisions would you make first? Would you A, initiate a treatment regimen of pembrolizumab, B, collect a biopsy specimen and start that biomarker testing, or C, begin a treatment regimen of trastuzumab plus pertuzumab? We'll give it a second for some votes to come in.
Martin, do you give pembrolizumab up front to all patients?
Especially never smokers. It's a really good idea.
It's facetious, right?
Yes, please. This is sarcasm.
Not medical advice, yeah.
All right, we're seeing a few different answers, though, here, so
Interesting.
I think there's an opportunity for learning.
Sure.
Let's give it maybe just a couple more seconds. All right, I saw one more vote pop in. Okay, so the answer is collect a biopsy specimen and order biomarker testing. So Josh, do you want to tell us a little bit about this?
Yeah, I mean, without having biomarkers, you can't select the right therapy for patients. Remember, lung cancer is not one disease, it's many diseases. Defining the biomarker is critical, right? If you have a biomarker, you need to target that biomarker. And then, if the biomarker is negative, we look at PD-L1 expression. If PD-L1 expression is high or low, we then define what the treatment is. So, here, in a patient who is biomarker positive, I'm guessing, that's going to help us select the right therapy. A lot of patients are anxious and want to start therapy quickly. Martin, you probably have patients who say, I'm going to go to the next center to get treatment today or tomorrow. You have to educate them on the right biomarker testing for the right treatment.
Well, I do encourage the patients and to basically wait for the results. But if a patient goes somewhere else, I make sure that we transfer those results so they don't have to go start over again.
Yeah, so this patient has a HER2 alteration, and there are many different opportunities available. These are frontline trials here of trastuzumab deruxtecan, a HER2-directed ADC. I think this has already completed accrual here, and let's go to the next slide. And then zongertinib as well, where we have an FDA approval in the second line, the BEAMI Lung 2 trials, a frontline study randomizing zongertinib versus chemo IO, and as well as cevabertinib, the SOHO 2 trial, also randomized phase 3 trial. So if you're picking these patients up in the clinic and you want a frontline targeted option, there are trials available for these patients. And these are coming fast and hopefully going to be approved fast for our patients because we need frontline targeted therapies in the HER2 space.
Yeah, so I think the takeaway from this case is wait for biomarker testing as much as you can. If there's anxiety, it's okay to start chemotherapy, but hold off on the immunotherapy and encourage clinical trial enrollment at all times, right, where you're meeting the patient. So these are opportunities for frontline studies for patients to get access to targeted therapies. Fantastic. We'll move to round number 2, case number 2. We now have a 67-year-old male patient, not female, right, male, coming in with HER2 mutant non-small cell lung cancer.
Men exist?
Yes, men exist, and they can have HER2 positive disease, right? I think that's a big takeaway. So please be checking for biomarker testing. So this patient was previously treated with chemotherapy, now is presenting very concerningly with progressively worsening headaches. They've started to become persistent, sometimes accompanied by nausea and brief episodes of confusion. Has a long history of smoking and a family history of cardiovascular disease. Initially thought that maybe the symptoms were related to stress or aging. Spouse is very concerned, starts to report recent subtle memory lapses even, difficulty concentrating. This is new for him. Neurological evaluation and subsequent imaging unfortunately reveals multiple lesions in the brain that are consistent with metastatic disease, confirming a diagnosis of brain metastases. Which of the following courses of treatment would you now consider initiating your patient on? Would you initiate a course of SRS or whole brain radiation therapy, initiate steroids for symptom control, or identify and initiate a regimen of systemic therapy first? So this is what would you do first?
So while this is coming through, these are really tough cases. I mean, patients come into your office, they're symptomatic, we know we need to act quickly, but yet we're telling patients to wait for their molecular. So Eric, how do you deal with these in your clinic, this case?
Yeah, if I'm ever worried about intracranial disease, and I'm worried especially if they're having symptoms, neurological symptoms, which this gentleman is having, that is my priority. We need to manage that. We need to manage it quickly. We need to make sure the patient's taken care of. And we need to call in our multidisciplinary colleagues. I feel very strongly about that. What about you guys? Martin?
Well, we didn't have a lot of information about brain metastases details here, so CNS positivity or negativity is really dependent. This is a symptomatic patient with looks like multifocal presentation, so this might be a patient that has edema. There wasn't any comment on this, so I think the steroids may be a very reasonable call in a symptomatic patient. It's typically a pretty bad sign when you have positive CNS symptoms already. I think depending on the distribution, the patient may be a candidate for targeted or for whole brain radiation therapy in the symptomatic setting. I'm very worried about this. If there is smaller lesions, typically a centimeter or so, or less even when they're symptomatic, I do think a short course of a targeted therapy is reasonable, but I would scan no later than 4 weeks into a start of a targeted treatment course. That's why it's so important to have these mutations up front, because you're going to be using them in the second-line setting for the vast majority of patients. So in this case, the diagnostic delay is very minimal. But it would be a case-by-case discussion, and a careful review of the MRI would really guide us here.
Yeah, I want to double down on that. To what Eric said, you need to treat symptoms up front here. That is critical, right? I mean, we're not waiting for, drug, sort of options for the patient, if in a symptomatic patient. And sometimes we even, have our, colleagues, radiation oncology, surgery, see these patients up front. But I agree with you. In an asymptomatic patient, small lesions, we can sit on our hands a little bit here, and we know that targeted therapies do have CNS penetration here. Which ones have the best CNS penetration? You'll hear it's coming up.
Tell us a little bit about Destiny Lungo 1. We'll take a step back.
Yeah, so Destiny Lungo 1 was the first study that showed efficacy for a HER2 ADC in the HER2 mutant patient population here. And you could see, very durable responses on this spider plot here. Let's go to the next slide. Response rates were about 55%. Median progression-free survival was impressive in that 9 to 10-month range. Interestingly, there's 2 dose levels, the 5.4 milligrams per kilogram as well as the 6.4 mg per kg. In the higher dose level, we saw better responses and better durability. Unfortunately, we also saw higher rates of toxicity, very high rates of ILD, as well as stomatitis and other, druxtecan-based toxicities. So the approval here is the 5.4 mg per kg once every 3 weeks, and had been a standard of care in the second-line setting. Here's the BME lung. Am I doing this one?
Yeah,
you doing
please.
This one?
Yeah.
All right. So here's the BME lung, and we were, participating.
It's
in
really
this.
good when you have somebody who does all your slides for you.
You both are ready. It's great.
Martin, you do it. It's all you.
Well, I mean, I think you were in a good flow, so I'll leave that to you.
All right, I'll take it. So we were fortunate to enroll onto this trial, and it's exciting to see a targeted therapy in this space, right? I mean, this drug, zongertinib, is a HER2-specific TKI. Here's the phase 1 dose escalation and the expansion, and we saw in patients with previous treatment, north of 50% response rate in untreated patients, high response rates as well, and we also saw intracranial activity. So this is data presented at ACR, published in New England Journal of Medicine. So 12.4-month median progression-free survival, response rate 71%. So this to me was the first targeted therapy differentiated approved with very little toxicity. So cutaneous toxicity, very minimal, about 1% grade 2, 3, and then also GI toxicity, very minimal, so low rates of diarrhea. So one of the exciting agents in this space. You want to talk about SOHO for cevabertinib?
So we have 2 agents now, right? 2 TKIs. It's a little bit different. Cevabertinib has affinity to both EGFR and HER2, so we have a little bit of a different side effect profile. The efficacy, as you can see, was very strong. We've seen response rates really upwards of 70% here as well. Obviously, many more patients do benefit. Response rate doesn't capture really the full reach of a drug. The median PFS here, 8.3 months. And you can see that when we come to sequencing discussions, there is quite a differentiation between those patients that did have a prior HER2 ADC targeting or not. The response rates here going down further, 35%. In a subsequent line therapy setting, this is probably still multiple times better than what we would expect from standard of care, but it has to be kept in mind. It has to be kept in mind for patients that have brain metastasis. Obviously, we want to look at this with sort of a little bit of a view of odds of response, and a 35% response rate, very different level of cautiousness when I think about relieving symptomatic metastases. And obviously, the treatment-naive number here with the best long-term outcome is clear. We don't induce as many resistance mutations. So this is a very promising agent. It's a little bit different when I look at the number of CNS metastases, maybe a little bit higher responses, obviously not head-to-head compared. What we do see differentiating in the toxicity profile is a little bit more GI toxicity. I think the EGFR targeting there is quite noticeable. So that's something that we have to work through with patients to make sure that we provide anti-motility agents and other supportive care. But I think the data here in the brain is quite interesting.
Yeah, I agree. And I think it's interesting when you compare this data to what we had historically, docetaxel, ramucirumab. There we're seeing 20% response rates, PFS of 4.5 months. These are really differentiated, targeted therapies. Now, when we compare cevabertinib to zongertinib, I agree with you. I think that the brain data here was a little bit more interesting to me. But that being said, more YVMA patients here, less complex disease. We know that tyrosine kinase domain mutation patients may perform differently than non-tyrosine kinase domain mutations. So when you're looking at HER2 mutation, it may be even more important to look even deeper at what type of mutation is there. And there's a lot of data now emerging in this space.
Yeah, so a lot of important points highlighted here. The type of HER2 mutation, is it an activating mutation within the tyrosine kinase domain, looking at the different cohorts in these studies, right? Are they treatment naive? Were they exposed to prior lines of treatment? Were they exposed to HER2-directed therapy? What about CNS metastases? A lot of questions for getting a lot of complicated answers to help our patients, so thank you both.
And I guess truth for CNS disease, it's really important that we study active, untreated disease, right?
Absolutely.
Not prior treated disease. I mean, these are all sort of, prior radiated or stable. So really to understand untreated, active CNS metastasis will be very important. And we hope to see data like that in the near future.
Thank you both. All right, we'll move to our last case of case craze. So we now have a 65-year-old female patient with HER2 mutant non-small cell lung cancer, currently receiving her second line of treatment with trastuzumab deruxtecan. She's now presenting with a gradually worsening shortness of breath and a persistent dry cough. Red flags are going up, not in the room, but just in clinic. She has no history of smoking, making these new respiratory symptoms quite concerning in the context of her ongoing therapy. On exam, appears to be mildly dyspneic with reduced breath sounds at the lung bases. Prior to imaging, which of the following might you most suspect is starting to cause these symptoms? Is it pneumonitis, pulmonary edema, or pulmonary embolism? We'll give it a second for some votes to come in. All right, so online and in the room, we're seeing a lot of consistency here. All right. So pneumonitis is what I'm seeing as a primary answer. Let's give it a second to undo the polling and we can move forward. Martin, do you want to tell us a little bit about some of the potential adverse events?
Well, I do want to say when it comes to diagnosis, you need imaging. I think ILD pneumonitis is a concern, but it's among many other things that could cause chest symptoms. You could have pulmonary overload with targeting HER2 on the myocardium as well. So you could have left ventricular dysfunction leading to volume overload. You could have a PE. You could have new tumor progression. So I get a CT angiogram. It covers most and it has a with and without contrast phase. I know that from a diagnostic standpoint, a high-resolution CT is probably best, but in order to capture all the potential diagnosis, the ER is probably a CT angiogram most likely to obtain. We do obviously see brain activity, flip side here, embryofetal toxicity. It is a chemotherapy-based agent, and we see some non-specific release, so hematologic toxicity certainly a concern. And then, like with trastuzumab, we like to look at left ventricular dysfunction. The only good news here is the myocardium doesn't proliferate. So even though we see uptake in with an ADC, a non-proliferating cell is pretty resistant to a chemotherapy agent. With zongertinib and also zevabertinib, the on-target effects really dominate. And here we have the differentiation that zongertinib is very specific for HER2. With zevabertinib, we have EGFR and HER2 targeting. But the inner and outer surfaces are lined with HER2, and to a certain extent, obviously, also with EGFR, and that explains all of the side effects. We're very fortunate that those agents have gotten a lot better. I remember the old agents with bosutinib and others, where we sort of really struggled in delivering these drugs. So they're not only much more specific and much more efficacious, but also much more tolerable. And this is because, for whatever reason, we're sparing the wild-type counterparts for HER2. And I think this is a little bit of a preferential placement for zongertinib here in the toxicity part. Obviously, many patients will have some degree, mild degree, but very few will have significant challenges. And I think we've gotten very good in managing both the diarrhea and the dermatitis rash kind of symptoms.
Yeah, Josh, do you want to offer any tips or tricks about how to manage some of the toxicities related to these oral targeted therapies?
Yeah, I mean, honestly, we have agents in the EGFR exon 20 space, for example, that are far more complex than here. I mean, I think zongertinib and cevabertinib, both cutaneous-wise, are pretty well managed in clinical practice. I mean, mostly grade 1 and grade 2. For diarrhea with cevabertinib, it can be more significant. So thinking about dose reduction, for example, but maximizing your anti-diarrheals are critical. And having patients tell you early on if they're having symptoms. Managing lights, for example, could be important as well. We've had other drugs in the past where if patients have severe diarrhea, are not managed correctly, that leads to sort of worse outcomes in patients. And I think for both of these agents, they're both relatively well tolerated in clinic, particularly when we compare it to Enhertu, which is a chemotherapeutic. The risk of ILD for me is as high as 20-25%. And I'll take rash diarrhea any day of the week because it's manageable in a patient versus ILD, which can be irreversible, unfortunately. And I'm hoping there are patients in the room, they forgive me because I know rash and diarrhea are not easy, but those are tough for us to sort of think about in comparison to ILD.
Yeah, and I want to emphasize that as well too, right? ILD, pneumonitis, you don't really see those risks with these oral target therapies, and it's a real, true risk for patients that are on trastuzumab deruxtecan. And I think we all have had patients, unfortunately, where they've developed pneumonitis, can maybe exclude them for trials, right? It's very difficult to manage. You need a lot of multidisciplinary care. But on the flip side, these are opportunities for, I think, patient education and really just emphasizing proactive management strategies if you're on an oral targeted therapy, right? Like making sure patients know that you may develop diarrhea, that rash is going to happen, so making sure patients understand what may happen while they're on this treatment journey with an oral targeted therapy.
Right.
All right, well, thank you all for playing Case Craze. We are moving quickly. The games continue. So now we're going to play Spot the Difference. This one's fun. I do a lot of patient education research. I'm really big on communication. And so if you've noticed, I've been very careful with how I've been wording and saying things because we want to empower patients. We don't want to have blame. We don't want to have stigma. ISLC has very nicely created a patient-friendly guide in terms of what type of language we should be using to promote really equality and to really get rid of the blame and stigma that a lot of patients with lung cancer experience. So that's what this is all going to be about. So we've got 2 rounds. You will be presented with competing statements, one that utilizes empathetic person-centered communication, and another that perpetuates stigmatizing language, which none of us want to do. After our MC, which is me, has presented you all with both statements, I'm going to count to 1, 2, 3. And on the count of 3, you'll raise your red flag in the direction of the statement that is perpetuating stigmatizing language. So I'll have to look with you on this side and kind of go with it. Don't hesitate. Raise your flag. If you're online, you can use the menti.com code. So I'll take a second for people to log back in if they need to. All right, so round 1. Let me read both statements first, and then I'll do 1, 2, 3. You have a HER2 alteration associated with your non-small cell lung cancer diagnosis. Here are some treatment options. Would you be open to discussing your tumor's HER2 status and what it could mean for your treatment options? All right, so let's see. If you are, let's see, the right side of the room will be the right statement, and the left side of the room will be that left-sided statement. So kind of point towards the direction. So we want the red flag where it's truly a red flag statement. Does that make sense? Okay, so 1, 2, 3. Do people move their flags? Okay. Okay, so it looks like more people are pointing to the left side. So maybe, Josh, do you want to talk a little bit about this?
It's confusing because it's reverse up here.
I know, right? Yeah. So we have to think about what we do when we're talking about radiographic imaging,
That's
right,
right,
for our
that's
patients,
right.
right?
It's
So
the
patient
counter.
left, patient right, so think about it that way.
Yeah, I think when you meet a patient, you want to be as sort of open and as forthcoming as possible. And I think, would you be open to discussing your tumor and HER2 status and what therapeutic options are available is the better statement here. Each doc, each team has their own personality, their own unique. But patients do really want to hear opportunities. They want open-ended. They want to be able to answer questions. Narrowing them early on, these are your targeted therapies or your therapies for HER2 mutation, I think sort of closes off the discussion. So I know, Martin, in your practice, you're probably discussing all of these options that are available to patients.
I do. I do have to say that a lot of patients still come to me for a recommendation. But when I discuss it, I have to be very careful. It's very interesting. Sometimes I have a patient from for a long time, and they 2 years ago you told me X, Y, and Z. They have the verbatim words that I used when I said it. And for me, this was probably not as carefully chosen as it was received. So you have to be very careful. So really phrasing this in a way, really seeing where the patient is at, where we are in our therapeutic relationship, and obviously matching this to my and the patient's personality also, I think is an important part. And obviously, as oncologists, as the eternal optimists, we have to be encouraging, seeking solutions rather than sort of being all gloom and doom for
and I agree. I think the most difficult question we get, Eric, and I'm sure you can comment on this in the clinic, is what would you do for your mother or your loved one? And that's really tough, but I think we should do the same for every patient, the same way we would treat our mother or our loved one.
Yeah, I love all those elements that you both shared. I think Jill Feldman is an incredible patient advocate and a dear friend of mine, and she's talked a lot about informed and shared decision-making, right? You can't just have shared decision-making if you don't inform the patient about options. So I really do think you need to be discussing all the options. You can lose a lot of trust, too, from patients and their families if you go down, you put your money down on one drug, and you don't mention, hey, there are other options, right? They go online, they find patient advocacy groups, they say, hey, my doc didn't talk to me about the other two drugs, why not? So I usually talk about all the options. I say, let's have informed decision-making, then we'll use shared decision-making based on patient preferences, based on their goals, based on what they prioritize in their quality of life, and then we make that decision together. And it doesn't mean that you as a medical oncologist can't put your money down and say, this is what I would do for my mother or my family member. I feel strongly that you should put your money down, but you should give the patients the information that there is different options that are available. So I think that's what this is highlighting.
Yeah, and also sometimes the toxicities that we view as significant or severe,
Absolutely.
Patients may not. So getting their input on what the toxins are and what they're willing to take on is important.
Yeah. All right, fantastic. All right, so same rules apply, okay? So round number 2, first statement, your history of smoking negatively impacts your lung cancer prognosis. Or to improve your overall treatment outcomes, let's talk about lifestyle habits that may play a part in this. So 1, 2, 3. All right, so most people are pointing to the left side of the screen as a negative statement that's perpetuating stigma. Online, it's split, 50-50, how things are changing, okay? All right, good. So, Josh, do you want to talk about this one?
Yeah, I mean, look, smoking is difficult, right? Because it's extremely stigmatized. A lot of patients, don't seek care because they feel that they are, caused this or, and I think the first thing I tell patients is I love you whether you smoke or never smoked, and I take care of you the same. And I do think opening up a statement about, what can we do to make you healthier, patients will tell you, I should quit smoking. So we don't have to drive with your smoking is harming you. I think patients understand that and know that. Coming at it with love as opposed to judgment is far more important.
Yeah, and I agree. I mean, we talk a lot about this statement about anyone with lungs is at risk for lung cancer, but I think another part that I really try to emphasize with that is that no one deserves lung cancer, right? So they really need to go together in terms of that messaging. Just because you smoked, you should not have shame, you should not have stigma, there should be no blame. I think this is also impacting lung cancer screening, right? People are really scared to go get lung cancer screening because of the shame and the blame that's associated. So I think that's a big component of why in the United States, less than 20% of eligible Americans are going for lung cancer screening. So we need to do our part across all the various stages of this treatment journey and diagnosis journey. All right, well, thank you for playing Spot the Difference. That really wraps up all 3 of our games that we played today for the Game On HER2 Positive Non-Small Cell Lung Cancer. Really want to thank everyone for coming together collectively here in snowy Chicago and online to participate in the North American Lung Cancer Conference. And thank you, Josh. Thank you, Martin, for being here and sharing your expertise. If you can please scan the QR code, you'll be able to download the slides, there's practice aids, and you can complete a post-assessment test where you can claim your CE credit as well. We're happy to take any questions as well, too, in the remainder of the time, so thank you.
All difficult questions go to Martin.
That's right.
Anyone in the room with some questions?
Nothing? Wow. All right.
You guys raised the flags a lot higher than your voices. No, I'm just kidding. Well, great. Well, thank you guys so much. We're happy to take any questions offline too.
Thank you.